Hear me? You can wave your hands. Thumbs up. Everyone can hear? Good job. I have everyone muted naturally because there'll be a lot of background noise. So welcome everyone. I am Melissa Brockett. Thank you for joining. Today, I'm sorry if you see me looking down. I have it on Facebook Live as well. So mind my eye contact. So what we're going to do tonight is speak about New York reopening. We know what's going on with the pandemic, coronavirus, COVID-19. A lot of people have been infected. A lot of people have expired, in other words, died. And I felt that it was very important for us to open up a forum to talk about the next steps. And what's most important, I find, for us to discuss is what's been on the news about our Black and Brown communities being most affected. So we're going to get into that in a moment. So as you see here, it's New York reopening, yes, and what should we do? So we're going to have our board certified doctors, two very awesome people. Dr. Shari Andrews, she's an attending ER physician, and Dr. Latif Salam, who's an attending internal medicine physician. And we're going to have a few questions. We're going to have them discuss their points of views from the different areas that they do work. And we're going to have some questions were already emailed and sent to me. We're going to have a section for that and a section to raise your hand. So I'm going to move along and we're going to get into it. Okay. So once again, I'm Melissa Brockett. I'm the manager here at FAEM. And again, the purpose of this event is to have an open forum, right? The Black and Brown communities are affected the most. And this is a very warm environment, a non-judgmental environment. But I felt that it was most important for us as part of the Black and Brown community to speak to everyone on a one-to-one basis. So background of me, I am a registered nurse and I work in the emergency room. I've also worked in home care. People know it as visiting nurse. So I've seen both when you're coming into the hospital and when you are discharged and you went home and now you need someone to help you when you're home. And I decided to go along and ask two doctors who are on both ends as well to give their input from a physician's point of view and to speak to you on a one-to-one basis, because a lot of times we turn on YouTube and we see a doctor from like New Zealand or across the world somewhere. We see directors and CEOs and everyone speaking on like a high level conversation and they're answering questions, but they may not be answering your questions. And it's a little bit different when someone of your own community that you identify with speaks to you. And I think that's what's most important. What I'm going to continue to say is, so the doctors and I spoke last night, and we just was going over the fact that we really hope that from this session that you are enlightened by something. And it's tons of good information. Like the doctors are so ready to talk with you guys, but just to be enlightened, to know something more than what you've known before, feel a little bit more comfortable, have the opportunity to ask something that's on your mind versus sitting there watching the news. The news has a lot of numbers. The news has a lot of information. The news has a lot, and people are beginning to it appears that people are starting to lose trust, especially here in New York. Like New York is kind of like opening itself without being told to. So we have to do it very carefully. I'm going to try to keep this within the 90 minutes, okay? I'm going to take up a few minutes of your time at the beginning, and then we're going to move along. A couple of last minute things. This is on Facebook Live, as I mentioned. I see it's going on here. So it's on Facebook Live. This is a recorded event, okay? So afterwards, you can always come back, share it, any information that was here that you just want to listen over again. That's the website where it's going to be. We're going to have 2 sections for question and answering. Another thing about Zoom, not everybody's familiar with Zoom. If you cannot see the speaker, you might have to swipe across your screen. You might have to, they have a speaker view and a gallery view. So you just might have to play with your toolbar a little bit, but we are here. We have a slide screen going. We're going to have some videos. We're going to have question and answering. And when we do the questions, you also have with the tools, a chat. So you'll just choose the chat button or you have a raised hand. So when it's time to open up the floor, I can go ahead and see who has questions. So right before we get into a video, I want to just say this disclaimer real quick, okay? The content in this Zoom session is not intended to be a substitute for medical advice due to any individual specific and personal diagnosis, medications, or treatment plans. The board-certified physicians and registered nurses who will speak with you all today are providing information and insight based on their professional knowledge and experience during this COVID-19 pandemic, in conjunction with their many years of practice prior to the pandemic. The views discussed here are not affiliated with any visions, mission statements, opinions, or goals of any health system that the physicians and registered nurses may be or have been employed with, okay? So this is a nice, friendly, warm environment where you can speak directly with me, registered nurse and manager of FAEM, and both physicians. Not affiliated with any health system that you may have seen us at. This is just us caring and loving our community, being part of the Black and Brown community. We want to be here for you. So moving right along, Spanish flu, right? Everyone's hearing about the Spanish flu, and for those who have not known what the Spanish flu was, it was in the 1918s, and it lasted for more than 12 months. And it infected 500 million people, about a third of the world's population back then, right? People grew sick of the same social distancing that we're doing now. They were just tired of it. Summer was coming, same thing that's happening now. Then when the Great War finally ended at the end of November, the people went to the streets and they wanted to have fun. Just like Memorial Day is coming and the 4th of July is coming, right? People, the beaches are open, same idea, all right? And then they went ahead and enjoyed themselves. And in the following weeks after that, the second wave came. And it killed more people than the war came. And I just felt that was very important to put out there because that is kind of like where our society is going, especially living here in New York, Brooklyn, New York. These folks are really doing whatever they want to do. And not everybody should have to pay those, pay the price for that decision. So let us learn something from that tragedy. I'm going to move right along to mask and gloves in public. Cuomo has told us all to wear masks. That is part of our fashion now, but not everybody knows what they're doing. Okay, we in the hospital have been fitted for N95. Those are special masks that are supposed to be worn by healthcare providers. Walking around with a 95 isn't a smart thing to do because there's no reason for you to do it, just walking around the street with an N95. A surgical mask, a cloth mask would suffice, as well as gloves. Everyone is wearing gloves everywhere that they go, and they're touching everything. They're touching their phone. They're just doing everything, and there really needs to be some type of dialogue, some type of correction, some type of education. So let's go right ahead and move into 2 videos. That's going to go ahead and speak. This is from our very own Dr. Andrews. So you'll meet her a little bit before time. So let's move right along.
It is quite evident that people do not want to get their hands dirty. So what is being done is that we're wearing gloves out in public. These should be used by individuals who are medically professional or trained in its usage. Wearing gloves does not take away from the very important fact that we must wash our hands well with soap and water. Wearing gloves, people are doing something that's very detrimental to your health and others. Cross-contamination. You touch an object that might have virus, bacteria, and then you're touching your face, you're touching your phone, you're touching everything with your gloves with the goal of not getting infection onto your hands. However, what you fail to realize is that with your gloves, you are touching things and not washing them, right? Because the mentality is that you don't want to get your hands dirty, but you're getting the gloves dirty. And in getting the gloves dirty, you then touch other surfaces like your face, like your phone, your purse, your groceries, you're just touching everything. And that's cross-contamination, which is very, very, very dangerous. Probably more dangerous than if you were to touch it with your hands. The idea is, classically, it is known that an individual will touch their face at least 20 times within an hour. That's a lot. The idea behind washing your hands well and washing them often is so that we practice good hand hygiene, and also I need you to be aware not to touch your face. This is a very simple concept, but it's also not easily remembered because human habits take us in a different direction. So just remember, it's more important to wash your hands. It's okay to go outside. It's okay to touch a surface. It's okay to grab your groceries with your bare hands. But try to keep your hands out of your face. Try not to touch your eyes, your nose, or your mouth. Your skin is probably the best barrier we have. But it's when we take the bacteria that gets onto our skin and touch our mucous membranes that infections can enter. Wash your hands well, and I guarantee you'll be doing a lot more than walking around with these. Another problem with these is that they're starting to be littered in the street. People are throwing these gloves in the street, just leaving them there. You need to dispose of these dirty, very dirty items in the trash. Very important. So I hope that I was able to shed some light. I really, really urge you to just lose the gloves and make sure you're washing your hands well as keeping your hands out of your face. Take care, everyone. Until next time, be safe out there. Do you know why you wear a mask? Of course I do. I don't want to get infection. I don't want the coronavirus. Okay, well, look at it this way. You might have the coronavirus and not even know it. So wearing a mask may protect other people from catching it from you by blocking your infected droplets from leaving your mouth and nose. The mask may protect you from others, with the exception of your eyes, but also it helps so that you're not touching your face with your hands that may have touched an infected surface. How do you put on your mask? Yeah, like this. You have to cover your mouth and nose. Like this. Hang on. So then, yeah, I had it right. The mask has two sides. There's a blue side and a white side. There's also a metal bar at the very top. That indicates top and bottom. okay? Blue sides on the outside, metal bars on the top. You clean your hands before you handle your mask. Hold it by the ear straps, put it over your mouth and nose. Metal bar molds to your nose and cheekbones. Underneath, you pull and fit it under your chin. Thanks. Now I know how to wear my mask. Why didn't anyone ever tell me this before? It's amazing. Your mask is a barrier, right? It blocks coronavirus from getting to you by your nose and mouth, and it blocks potential coronavirus droplets from exiting. Therefore, there's coronavirus on this mask, inside or out. Never touch your mask by the face or inside. Always handle your mask by the ear loops or straps. Take it off carefully, being sure not to touch the outside, and then discard it in the trash. Once you do that, you sanitize your hands. Into the trash. Thank you so much.
Okay, I hope that was so awesome. I really liked those when I saw them. I said, man, I gotta let everybody see what Shari has put together because it's so important. And I hope that you all really, really got some really good information from it because, you know, when you don't know, you don't know, but now you know. So let's move right along. I think I'm having some chats here. I'll check that in a moment. Let's move right along to Dr. Shari Andrews. Okay, Shari, are you on? Let's double check. There we go.
All right. I was waiting for you to unmute me. Good evening, everybody. My name is Shari Andrews. I'm an attending emergency room physician. I work here in New York. I have been working in the emergency department for the past 10 years. I love my job. I mean, what can I say? We see just about anything that walks through the door, you can imagine. And that can be from something as simple as an ankle sprain all the way up to cardiac arrest, stroke. We see it all. So as you've heard on the news, especially with this pandemic hitting the world, we're front and center. We see every patient that walks through the door, and lately it's been only coronavirus. So what we learned early on, what we realized is with COVID, there's been a progression in the way, not only the way people have presented to us, but a progression in the way that we have managed cases that present to us. In the beginning, we received an alert from the CDC that there was revelation of the coronavirus. There were at least 500 cases in Wuhan, China, and that we should be aware that if anybody travels in from Wuhan, China, that we should be on alert that these specific presenting signs and symptoms, fever, cough, cold, shortness of breath, were what we should look towards calling the Department of Health for so that they specifically can get on the case and do testing. That's how it began. And then a week later, it's not just Wuhan, China, it's Hubei province in China. And then 3 days later, it was the entire, everything, China. And then 3 days later, It was China, Iran, Korea, and so it went. Testing was greatly limited because the CDC was the only place that can do a test. We had to go through Department of Health. They had to do their investigation. Patients were treated and released. And that's pretty much how it started. It wasn't until a good 2 to 3 weeks later that then they said, you know, there's now community spread, and we need to not only test those who have traveled, but those who have the presenting signs and symptoms. And so we did. What I'm going through here with you in discussing this progression of things is to let you understand that the dynamics have changed with like great fluidity. It has gone from a concern for just a province in China to now the entire world and everyone in it. The testing not only opened up to those who had fever, cough, shortness of breath, or viral-like symptoms, but then we were getting patients who came into the emergency department with other complaints like loss of smell and taste, vague sore throat, abdominal pain, right? The abdominal pain is what really threw a lot of us, because a patient would say their belly hurts. We would do our physical exam, take our full history. It would sound a lot like something else. You know, maybe it could be an infection in the colon, maybe it could be a kidney stone. And usually when we have that type of a concern, we would perform a CAT scan to see what's going on. So we'll go over to CAT scan, we'll get the scan done, and then the read would come in. No findings within the belly, no abdominal findings. However, there are findings within the lung, because the belly CAT scan picks up the bottom portion of the lung. And that's when our eyes opened wide, like, what is going on here? Patients have abdominal pain, they have chest pain, they can have heart attacks. We've seen strokes. In our elderly population, they will come in unresponsive, breathing, but unresponsive. We call that encephalopathy. And this would all be secondary to COVID. So that's when we realized that this was more than we thought it was. And from my lens, you know, it was scary. It is scary, because we can be walking around and can have the mildest of symptoms, if any at all, or we can be fighting for our lives in the hospital. And that's a scary thought, because then came the advent of the asymptomatic patient, the patient who has absolutely no symptoms, yet can transmit virus, which is unheard of. And so with that being said, as the community is learning about the coronavirus, to be frank, so was the medical community. What we realized was that the emergency departments were getting swamped with cases, not only of the patients who were sick, who were very ill, who needed our attention, but also with patients who just wanted to get it checked. You know, like, I just want to get a test. I just want to know. And at the end of the day, what we had to do was classify that coming to the emergency department, where emergencies are, we needed to really, like, you probably saw all of the posts going around social media about, we come here for you, please stay at home for us, right? Something like that. And the whole notion behind that was, we can't be inundated with the walking worried, those who are well and breathing and doing okay, but worried and wanting to get a test, because we really had to focus our attention on those who are very sick. So then what happens now is the media portrays what's happening. You see what our frontline workers are experiencing and going through. And now people are afraid to go to the hospital, because these social media viral videos are going around explaining that hospitals are killing people and putting people on ventilators, and the ventilators are killing our community. So now you can be with stroke-like symptoms, chest pain, heart attack, You know you need to go to the ER, but you don't want to because you don't want to go on a ventilator. And that's where it became very scary, because now, or lately, what we've noticed is the volume in the emergency department has greatly decreased. So when we were once swamped with cases left and right, now it's barely. So then I have to wonder, well, where are the heart attacks and where are the strokes and where are the people who have emergencies? Because emergencies are still happening. And we want to make sure that people can get past the mental block of fear, where they are afraid of coming into the hospital for medical attention when needed because of, I guess, the unknown, right? I'm never going to see my family again. I'm going to be placed on a ventilator and never come off of it. And that is the reality. So let me just skim through these questions once more and see if I covered it all. What should continue or be implemented as we begin the phases of the New York reopening? Well, I think that social distancing is effective. We definitely are seeing a decrease in new cases. However, there are still new cases. The thing is, we see that social distancing is working. Using a barrier on the face, on the nose and mouth is working. However, when we reopen, because cases are still out there, transmission is still possible. Therefore, resurgence, or the second wave, as we've all been putting it, is also still possible. So we have to remain vigilant and ready for that. Melissa, you mentioned that New York seems to be reopening itself. If I take a walk outside right now, I'm pretty sure the streets are packed, as opposed to that eerie, quiet feeling that there was not but 2 weeks ago. People who are wearing face coverings are wearing it on their chins or underneath their nose or on top on their forehead. And what's the point? So I guess we'll have to see how things go. I agree with a slow reopening. I agree with not just going right back to normal from like 0 to 100. However, we still have to be careful amongst ourselves on a personal level, because we're still wanting to have Memorial Day weekends coming, but we're still wanting to have our family gatherings and the like. And I think that does not help the situation at all. I just had a case yesterday of a young woman who came in with her 2 children, all 3 of them to be seen. And I said, well, what have you been doing lately? Are you going out? What's your level of interaction with others? Well, they were doing a parade. So someone's birthday, and they were driving by and honking the horn and putting like signs outside of their window or their car door to say happy birthday as they drove by. Well, she mentioned that they stopped. They stopped and they got out of the car and they talked with the person behind them because they haven't seen them in such a long time. And now she realized that her sister had COVID, and now we have fever and cough and whatever. And it's like, we're worried that we might have it too. But what was the point of the drive-by if you were going to come out? All right. So my point is made. So what I'm saying is we still have to remain vigilant. It's not over yet. We do not discharge patients from the emergency department on hydroxychloroquine and not necessarily on a Z-Pak. We usually recommend supportive care, which means support your body well, take Tylenol if there's any fever or body aches. Our emergency department, as well as some others, discharge patients who might have pneumonia on their x-ray or might have a decreased oxygen level. When we check it, we'll send them with an oximeter, which is a device that checks their oxygen level. They can use it at home. That way they'll know if to come back into the hospital when needed. Unfortunately, everybody cannot be admitted. But it is not routine to discharge on hydroxychloroquine. The risks greatly outweigh the benefits. It's not good for the heart. So therefore, it's just vitamins, supportive care, rest, and that'd be all. Melissa sent me an article today. I didn't get to go through it, but COVID-19 is definitely a challenge to our mental health. We've heard of the suicidalities that's been happening amongst our frontline workers, even in patients who are home with mental illness and can't seek the attention that they need during the time that they need, because lots of doctors' offices are unavailable, not open, not seeing patients. So we do want to also spread awareness that we can seek other resources to maintain our mental health and strength. All right, I'll turn it back to you, Melissa. You let me know.
You did awesome. I put a few things there. You went through everything. What's going on in the emergency room, the signs and symptoms when it first started. People are coming to the hospital, and just like, you know, before this, they come to the hospital knowing they shouldn't be there, and they want a Motrin because they want something. They want to feel like they left their house, they went to the ER, they got registered, they waited 3-4 hours, and at least you do something. Give me some Motrin. And you can get the Motrin at the corner store. So it's the same thing. Oh my gosh, COVID is happening. It's going crazy. And I heard that you're supposed to take this medicine. Can you give it to me? And if you don't need it, you don't need it. And supportive, like a lot of people have gotten all these, like, you know, take vitamin C and take zinc and take this and take that. I want to stress the facts here right now, you know, with your support, of course, that you must take care of your health, regardless of what. You should not have to wait for COVID to happen to take care of your health. We know from basics that we have an immune system. Our immune system fights for us. If you are not doing the correct thing for your body cannot do the correct thing for you. And I just want to bring that in, if you can maybe talk about that as well in the emergency room, comorbidities. A lot of people have comorbidities. Comorbidities are other diseases that you may have. So you might have asthma and high blood pressure and heart failure and kidney disease and diabetes. And some people have all of those, plus had a stroke, plus had a heart attack, plus have a broken foot, and it is a lot, and it stacks up. And sometimes, most of the time, these things can be prevented if you take good care of yourself, right? Health, going to the gym, exercising, eating properly, not expecting the doctors to give you a pill. A pill cannot solve your problems. It can support it, it can correct some things somehow, it can put things into balance, but the first stop is with you. And I think that's something that people need to understand, that going to the emergency room isn't like a quick fix. And you've seen that a lot.
Yeah, and you know what? It's not that I disagree with a patient's will to know if they are experiencing the coronavirus, especially given the gravity of what we've been hearing about what it can do. It's that the health system as a whole wasn't prepared to perform as many tests as the demand required, right? And that speaks to the preparedness of this country. Now, I do agree that if you need to know if you have COVID, you should be able to find out. But we didn't have the capacity to do as many tests as we would have liked. It became to a point where if you're not getting admitted into the hospital, you're not going to deserve a test. You know, they had these testing centers, but I hear it's difficult to get, you know, an appointment, or you can't just simply drive up and get your test, you know. Even if you went to urgent care in the very beginning, it was not easy. Now that testing is widely available, you can go to the urgent care and have foot pain, no symptoms of COVID. I shouldn't say foot pain because now there's COVID toes, but you can have a sprained wrist and go to urgent care and they'll offer you a COVID test. And I think that, why couldn't we have been there before, right? Because I think that the common person would want to at least know, okay, sure, the test is not 100%. You can test negative and still have the coronavirus. We know that. But if a person knows they have COVID, they kind of think a little bit differently and they move a little bit differently. And especially with comorbidities, not that that dictates, you know, how they will handle COVID if they get it, but it does play a major role that we, as a whole, in general, before this, it is important to stay on top of one's health, you know. So, I mean, I 100% agree with everything you said.
Thank you. So what I'm going to do right now is I'm going to unmute Latif, which is our second doctor that's going to speak in a moment, because we're going to get into some questions. Latif, are you on it?
Yeah, I believe so. Can you hear me?
I can hear you. How are you?
I'm doing pretty well. Thanks for asking. How about yourself?
I'm not too bad. I'm excited. How are you? Are you excited?
Yeah, definitely. And, excited about, talking about COVID-19 to people and kind of enlighten them and giving them some answers to some of the questions that they might have. So, Dr. Andrews has done a fantastic job in kind of letting people know, what the general presentations and, what the ER or the ED, as we call it, have to deal with all these patients, the overwhelming of our system. And I think she's kind of painted a really good picture of how that was and where we are now. And, I'm looking kind of speaking into what I do a little more and just kind of shedding some light into what happens upstairs if you get admitted to the hospital.
Thank you. I appreciate that. I'm looking forward to that too. But I want to pause because we've addressed a lot so far. So I want to pause. I'm going to open up my screen, see who might have their hands raised. I see that there's some chats here. So let me go right ahead and see if anybody on this live has anything to say. So let's open up this chat. And no. Okay. So these were different chats. Anybody have anything to say? Okay, I see Deborah's hand is waved. Let me find Deborah. Let me know. Disappear. There you go. All right, you're live.
Hi, am I unmuted?
Yes, you are.
Okay, so my question is about the way people are visiting others' homes. How do you judge where you should go or not go? I know of cases where a household where the mom works in a hospital in a lab, manages a lab, and then the children are in the home, but the children go out to other people's houses. Can you give some guidelines on how you should interact with other people?
So I'm sure everybody has seen all of the signs and the news outlets telling us to stay home and flatten the curve. So the most important thing is to really stay home. We don't, life happens. You have to go out, you have to visit people, but we're not really encouraging people to intermingle and visit each other, especially trying to flatten this curve. So knowing that I work in a hospital, possibly I could have COVID-19 and not have symptoms. So I consider myself someone who's a higher risk to contracting COVID-19. So that being known, I'm not going to go to my parents' house who are in their 70s and spend a lot of time there, especially without protection and things like that. So if somebody has a family member who works in a hospital, that person is kind of at a greater risk than the general population, albeit we know you can get COVID-19 in the community, but it usually spreads through close contact. I think that's what we're kind of really understanding about how the virus works. So if somebody works at a hospital, that person could be a vector. So they should limit their interaction with other people and not visit too many people. If they are around people, take the appropriate precautions. This case will be mask, washing hands, not doing too much touching and things like that. So we want people to stay at home, and that was imperative in the beginning. It was quite imperative. And it was the reason why things got better, because we were overwhelmed. But as people started staying home and we were practicing this physical distancing, we say social, but really it's physical. We were practicing physical distancing, then we started to see a drop in the number of cases and people coming to the hospital, which was able to take off a load from people like Dr. Andrews and myself. So we don't recommend visiting other people's home or congregating just yet. But if you do have to, I think the most important thing is just kind of exercising the same precautions that Dr. Andrews and myself have kind of mentioned before. So I don't think we're there yet to be hanging out and doing things. And if you're gonna go somewhere, then just do the physical distancing. Don't be too close to the persons, and that's really it. So again, we can't force people to stay in their home, but just remember, be cautious of the houses that you're gonna be entering, and if the person in that house has been infected with COVID-19, if they don't, just play it safe and kind of stay in your house until things are much, much better, which they are getting better. And that's part of the reason why we're kind of easing the restrictions now. I think there's a plan to maybe open beaches or something like that in New York, parts of New York in the next few days before Memorial Day. I'm not sure, but I think I've heard that. So things are getting better. But if you do decide to visit friends, just do the physical distance and try to stay. Don't hover too close to other people. Make sure you're washing your hands. Wear the mask, and I think that's the best you can do.
Thank you.
Thank you.
That was good. Okay. Do we have any more? I think I had a. Let me see what this says. Oh, great question. I was thinking the same thing. Okay, so somebody agrees with that question. Any other hands that's going to go up for this section? No further questions? I guess we're doing quite a good job at answering questions. So we're going to move right along. We're going to move right along then. Thank you all. So, oh, Tiffany Tate raised her hand. Let me get to you. Hello, Tiffany.
Hi there. My question is in terms of going to the grocery store. Are there any necessary precautions we should take? I'm currently not using gloves when I'm in the grocery store, but my concern is that I'm touching things that other people are touching and putting them in my reusable grocery bag and then bringing it home.
Yeah, that's also a great question. Not that you need gloves when you go to the grocery store, because you touching anything with or without your gloves still means that you still have to wash your hands, right? But you raise a good point. You're taking the groceries and putting them into your reusable bag. Well, your reusable bag is considered contaminated, so you have to watch where that reusable bag then goes, right? So I don't know what happens when you get into the house, but when you get home with what you bring in from the outside, you should set everything down in a designated area. And as you unload your items into your home, you'll be cleaning and disinfecting as you do so, because we understand that the virus can live on surfaces. So it sounds OCD, but it is what we need to do. Of course, washing your hands still, goes without saying, also needs to be done. You raised an excellent point. Some people who prefer not to touch anything when they go to the grocery store do wear their gloves, but then if you wear your gloves and you're shopping, but then you get to the register, those gloves shouldn't be entering your pocketbook to get your wallet and your credit card and then your cell phone, right? So, or if it does, that's fine, but consider it all contaminated and they all still have to be cleaned and go through that process. So, excellent question.
So just to tag on with that a little bit, I didn't include this here because it's very long. I personally put up a video on my social medias, right? And it was doing the same thing. So in the hospital, what we do before procedures, especially sterile procedures, we have a dirty area and we have a clean area. And so we can take that same idea into practice in our normal day lives because it is tedious. It is a lot of work. And I say to myself, like, why did I make this video? Because I have to do it, right? But I do have to do it. So I do small grocery shopping because as I come in the house, I use their plastic bags that, you know, New York is not supposed to have anymore. So supposedly we don't have plastic bags, but we do. So I do not use the reusables. So I come in the house and the same thing. I have a table, and on one side I have my dirty section, one side I have my clean section. I have my bleach cloth, I have my Purell. And then as I take the items out of the plastic bag, they're dirty because I don't know who touched it outside, right? And then I take my bleach wipes, I wipe everything off before I move it on to my clean side. And then I continue to do that. And as the plastic bags are being used, that goes by the door. Unfortunately, I'm throwing my plastic bags away or making them garbage bags. I'm not gonna bring them into my house further than the door. So then as I clean them off from my dirty side and move it to my clean side, now I can put it in my cupboard and in my fridge. Now I know everything has been cleaned, and then of course wiping your hands in between. And it was a great point that you made because again, with the gloves, you're using the gloves, you're touching everything, and then you went and you got your wallet out. So now you took everything that you touched in the store and you put it in your purse. So now you got to clean your whole purse, right? Or what people are doing is taking those same gloves, going in the car and touching the steering wheel. And now they're going everywhere. So now the car has COVID. So it's just small things that you have to put into practice that you have to become OCD now because you don't know. I got another question here. Oh, Alina, Dr. Sam is the best. Dr. Salam, I'm sorry. So that was, I guess these are coming in privately. So yeah, you're the best. So we're gonna move right along to your section now.
Sure.
Wait a minute. Oh, hold on, we have a comment here. Since we are not healthcare professionals and only go to the grocery store or laundry, should we dispose of gloves on a daily basis?
Yeah, gloves are not supposed to be reused. So absolutely. You're supposed to use it one time and discard it. So you should be disposing of gloves multiple times on a daily basis.
Exactly. And that's good to know because that's the whole point of the shortage that we're having. Because we in the healthcare field, we use a mask, we throw the mask away. We use a gown, we throw it away. We use some gloves, we throw it away so that we do not cross-contaminate. And then when the shortage happened, that's why so many healthcare providers feel so stressed because it goes against our normal practices. Like you're telling us to wear one gown because we don't have any gowns. So outside is the same thing. That's why washing your hands is the most important thing you can do. You know, the gloves, but wash your hands. If you agree, tag on, but we have another question here. And I meant masks. What about the mask? Should that be thrown away also on a daily basis?
Actually, yes. Masks, especially the procedural masks, technically should not be used for more than 8 hours if used on a continuous basis. But it's a face covering that's recommended, right? But even those, when you get those, you need to wash them, right? I don't know if anyone's just putting them to the side and then just throwing it back on when they have to go outside again, but they need to be cleaned because again, that's a barrier. That's a barrier that's capturing particles, droplets, germs, and therefore you need to hit that with hot water and some soap and make sure it's clean. So yeah, if it's a cloth mask, clearly you can wash and reuse. If it's a procedural mask, even N95s, we technically shouldn't be using those again and again and again, over and over. So like Melissa said, it went against everything that we ever were trained to do. We go into one patient's room with an N95 we come out of it, that mask is trash, because why would you carry that into the next patient's room or your gown, right? And then now it's like we're wearing the same mask, not only for a 12-hour period, but not only for that patient, but for a 12-hour period. And not only for that 12-hour period, but for multiple days, you know? So great question again. And yeah, we're supposed to throw those procedural masks away.
Thank you, thank you. Questions are heating up. Okay, so we're gonna take these last two and move along. So I have another one here by Deborah. Hold on. I hope I'm saying your name right. Unmute.
Deborah.
Is it Deborah or is it Deborah?
Deborah. To follow up on the mask. So my husband and I had some like painter's masks. So those are like not the reusable cloth kind. But do you know what I mean? I don't know what
the one with the two round circular filters on the side, like it looks like a gas mask almost.
No, not that kind. It really almost just like almost like a cup, that it doesn't have the lines like the ones that was in your, let's see. No, isn't that the N95?
It is a type of N95.
Okay.
Like cup-like. So.
Not even like the one you did in your video. Mm-hmm. But it isn't cloth. So if it isn't cloth and it is that sort of
fibrous,
like paper kind of thing, is that a one-time wearing and tossing?
Yeah, again, I'm not quite sure exactly what mask you're referring to, but if it's a wash and reuse, then that's okay.
It's not.
Right.
It can't be washed. It should be tossed.
It should be tossed.
You know, due to constraints and limitations on the amount of PPEs that's available, right? We've learned to be kind of frugal with these things. So, you know, like Shari said, we were taught to use PPE one time and dispose of it. That's not the case anymore because we were overwhelmed. So technically, yes, I would say if it's not like she mentioned the cloth one, you should dispose of it. But also there was times when we have N95 mask and we would put them in like a paper bag and leave it in the paper bag for a few, you know, and reuse them for a couple of days before we got rid of it. But again, you shouldn't be using the same mask for, you know, 1 week, a week and a half. If you are limited in quantity, you might be, you know, forced to reuse, but we don't recommend it. Most masks should be used once and disposed of. But due to the nature of what's going on and how things are limited, we've been managing to reuse things at times, but we really shouldn't be.
So I have a question to add to that. If we have to reuse, right? So it's two things to be done, and let me know if you guys agree. If we have our shortage, so can we put it outside to air out and get direct sunlight to kill off germs? And two, spray it off with some Lysol, put it aside, and just alternate between 2 or 3 months.
So there's like a proper tool for disinfecting mask, right. And that's not, you know, that's not it. But, you know, again, we're kind of desperate. So sometimes if you just don't have it, you might have to be creative and kind of leave them and let them hang. And then maybe you might have to reuse it. But, you know, technically, really use it once and get rid of it. You know, but that's not always feasible.
Okay, last question. Last question is, what about wearing shoes in the house? So me personally, the same thing that I did with the clean and dirty. As I come in, first of all, I don't want you wearing shoes in my house without the pandemic. There's a lot of germs out there, and I don't want them in my house without the pandemic. So now with, and again, the gloves are on the floor, the mask is on the floor. So those are full of COVID. It's all over the place, right? So I take my shoes off, I put them in a plastic bag, especially the ones that I wear to work. I wipe off the bottom with bleach wipes and Lysol them. That's my practice. Once again, the doctors will let us know what is the best practice.
Shari, you want to answer that?
No shoes in the house at all. Like, you know, no, don't do it. You're tracking in outside into your home.
There we go. I hope that answered that question.
I could give you a long, drawn out explanation, but the bottom line is no shoes in the house. I don't recommend it.
Okay. All right, everyone, let's move along. So, Dr. Salam, it is your turn.
Okay, great. So my name is Latif Salam. I'm an attending physician in internal medicine here in Brooklyn, New York. I take care of patients who are admitted to the hospital. So if you go into the hospital, you'll see Dr. Shari Andrews first. And if she thinks that you're not well enough to go home, she'll likely admit you. And once you are admitted, I will take care of you until you go home, which is the goal. Or if, unfortunately, if you're not doing well and things kind of go south, you go into maybe a step-down unit or the ICU, where the most critically ill patients are cared for in intensive care unit. That's what the ICU stands for. So I take care of patients who are sick enough to be hospitalized, but are not so sick that they need intensive care. I actually also take care of patients in a step-down unit, which is a sister to the ICU, which is somebody who's sick, but again, not critically ill, and I can manage those patients on my own. So, you know, as an internal medicine physician, I take care of adults, ED doctors, such as Dr. Shari Andrews, take care of adults and children and pediatrics. I do not take care of pediatric patients. I only take care of adults, mostly young adults and regular adults and elderly. So those are the patient age range that I'm accustomed to taking care of. As far as presentation, signs, symptoms, once these patients are admitted, I think one of the reasons why patients with COVID-19 patients will be admitted is due to what we call, you know, hypoxic respiratory failure. That's a fancy term for low oxygen level. If you come into the ER and, you know, you're complaining of, you know, we know what the symptoms of, some of the symptoms of COVID-19 are. Dr. Andrews mentioned them. But some of the things that will kind of make you worry about the person would be somebody who's complaining of being short of breath. And, you know, shortness of breath, we can see that by the way a patient is breathing. We can look at them and see if they're what we call tachypnic, meaning breathing really fast, or they're using what we call accessory muscles or breathing with their belly. That's not a physiological or normal way to breathe. And if you're, you know, ill with COVID-19, which causes a respiratory, can cause its respiratory suppression through the pneumonia, the viral pneumonia, or even a bacterial pneumonia that could be superimposed, you're going to have problem breathing. So if your oxygen level is low and you're hypoxic, it's unlikely that you'll be going home. And if your chest x-ray shows a pneumonia and you are hypoxic, I'm going to be taking care of you. So, you know, signs and symptoms, we know what they are: cough, fever, chills, maybe some abdominal pain, sometimes diarrhea. Some are like non-specific, just not feeling well. Myalgia, which is muscle ache. And then I think the sinister signs and symptoms are like difficulty breathing, which we call dyspnea. And if you're labs are abnormal, that might be another reason why you might be admitted. So labs being abnormal means they do a blood test and some stuff looks really funky, and they want to watch or try to correct it. So I think that kinds of answer the signs and symptoms of these patients. And prognosis really depends on, how sick you might be and how you respond to therapy. One of the things I remember at the height of the pandemic was we have a service called palliative care, which is a service that take care of people who are not doing well at all, and we don't think they're going to make it. One of the harsh truths about COVID-19 is we saw a lot of death, and I'm sure the people who are online now saw the tallies and the totals on the news every day. And, we were in the front line, and we saw that firsthand in the hospitals and from the ERs to the wards. So some people will come in already with cardiac arrest or respiratory arrest. Those people, their prognosis is very poor because they came into the hospital pretty much near death or already dead, for lack of better term. And those people, you want to get palliative care involved in their care so that the family knows that unfortunately doctors don't have any superpower, and that we're not going to be able to reverse some of the deleterious thing that COVID-19 has already done to their loved ones, and that we don't think the patient is going to make it. So those patients, unfortunately, they're not going to do well. They're probably going to succumb to COVID-19. Most of our patients who might just have a little problem breathing, we give them some oxygen. We give them supportive care, which is basically just kind of address whatever the underlying problem is. Let's say you have really bad diarrhea, and your electrolytes, which is your chemistry, your sodium, your potassium, all those things are off. We try to fix those things, and then see how you feel, give you fluids, and then go from there. The other thing that we learned as we started taking care of more and more COVID-19 people, and more literature came out, was that some people were dying from clots in the lungs, something called pulmonary embolus. So once that word got out, we started giving some people with certain tests called a D-dimer. If it's above a certain value, we would put them on blood thinners. It seems like people got better with that. Some people got better with the blood thinners. And really, your prognosis just really depends on how sick you are when you come into the hospital, and then, how well you respond to the therapy that we give you. If you can't breathe and we give you just a little oxygen, the nasal prongs under your nose, and, give you some extra oxygen, and your oxygen level goes up, that's a good sign. And, maybe you'll feel better, and we can probably send you home. If we can't take the oxygen off and your oxygen level stays low, then maybe you can go home with oxygen until maybe things get better, or maybe not. But there are some people where we'll give them oxygen, but they just continue to deteriorate and they don't do better. And those are the ones that might end up wearing what this guy's wearing, which looks like a high flow nasal cannula. And then if that doesn't work, there's something called a BiPAP, which is a very uncomfortable mask that we have to put on people's face. People don't like it, but that was something we were using. And initially, we didn't want to use it because we said it aerosolized viral particles, and we didn't want to get other people sick. But then we started using the BiPAP, and then if the BiPAP doesn't work, then it goes to the tube. If we're getting to the point where we have to put a tube in your throat and you need to be intubated, things probably are looking really, bad, and prognosis at that state is probably much more poor and worse than if you don't need it. So if God forbid, if you had a family member that was hospitalized for COVID-19 and the doctors are saying his oxygen level is low, he's breathing really fast, and he doesn't look good, and we need to put a tube in his throat and intubate him and put him on a ventilator. There was a lot of noise about ventilators. If you get to that point, again, prognosis is probably poor. Some people will be able to go on a tube on the mechanical ventilation and come off, but a lot of people will go on and unfortunately die on the tube. So that's something that we should always discuss with our loved ones about, you know, if they ever want a tube in their throat or not. Shall time come for something like that? Some people will say, no, I never want a tube in my throat. I never want to die that way. So that's understood. And then, you know, you would sign what we call a DNI, and that typically comes with a DNR, which means no CPR and no resuscitation, because the two of them kind of go hand in hand. So some people will sign a DNI and a DNR form, meaning I never want a tube in my throat because, you know, I don't want to die like that. So I think that kind of gives us a picture of prognosis as you present and as you improve or not improve with the therapy that we give you. The next thing is what should be done at home as patients are discharged. So again, if you come in, we admit you for a day or two, we give you some oxygen, you feel better, we think you can go home with or without oxygen. You know, you might still be COVID positive. Being positive does not mean you can't go home. I think people need to understand that. Because remember, you might come into the ER and Dr. Andrews might say, I think you can go home, but they just told you have COVID-19. So people might say, I don't want to go home, I have COVID-19, but she doesn't think you're ill enough and she's comfortable with, you know, her assessment to say, I think you can go home. Maybe the x-ray wasn't too bad. Maybe, you know, you run around and your oxygen level is still really good. And she said, you can go home. So I think people need to understand that just because you have COVID-19 doesn't mean you're going to get admitted, right? Because, you know, she's only going to admit people she thinks needs to be watched or taken care of, you know, further in a hospital. So we discharge people that are still COVID positive. So when they go home, what should they do? They should obviously quarantine themselves, right? You go home, you stay away from people. The CDC guideline is for, they were saying 3 days of no fevers or 7 days, but we know 7 days might not be accurate. So I still tell my patients, I think 2 weeks of quarantine, it's better, it's safer. So that's why I still say, but based on the guidelines, they say 3 days of no fevers or 7 days. So, but I still kind of recommend, you know, at least, you know, 10, maybe 14 days of staying away from people in the house, maybe just kind of stay in one room, wear a mask, make sure people are washing their hands if they come in contact with you on multiple occasions. Maybe one person will be designated the contact person to bring you whatever you need, and use a different bathroom if you have multiple bathrooms in the house. So again, you know, those are some of the things that you must do when you go home, as people will be discharged who are still COVID positive and might still even have minor symptoms. So that's things that we recommend. And then the other thing we typically do when people go home is, and one of the things you can ask for from the doctor if you happen to be admitted for COVID-19 and you were being discharged, is a nice pamphlet or printout of, you know, of what you should do at home and how you should follow through with the quarantine. So that's something that we can always print for you so you can have, and you can follow that rule until, you know, 10 to 14 days is up, when you're no longer in quarantine and you can kind of, you know, go back to being with your family. Are we discharging people with Lovenox? So Lovenox is the blood thinner that we give certain people if a certain blood test is above a certain value. So the guidelines of Lovenox is kind of, I mean, obviously there is no guidelines, but the literature is saying that we give it to people for up to a certain time, and then when you repeat the same blood test, if it goes below that value, a certain value, then you can stop it. So I don't think we discharge people with Lovenox. I've also read certain other protocols that said maybe send people home with a Pixaban for up to 2 weeks. So it's kind of weird, but blood thinners are not, you know, mandated. It's just, again, this is all practice that we we're using from different protocols from different institutions, because, you know, what we know about COVID-19 is still changing and it's dynamic. So, you know, today we know this, tomorrow we know something else, and this that we knew yesterday now is incorrect. So that's the thing with COVID-19. Information is changing on a regular basis, and with the new information that we have from literature and clinical trials and studies, we're implementing that information by changing how we manage these patients. So as far as blood thinners, we use them, but I have not been sending patients home with them. And then from my lens, how can people take more control of their health in the community? So as an internal medicine physician, I think the most important thing is kind of like preventative care. You know, that's the most important thing, because, you know, I serve a predominantly Black, low socioeconomic community. And it's unfortunate because, as we know, that's the same kind of community that was disproportionately affected by COVID-19. You know, and I think a big part of the problem is just that, like what you said, Melissa, about the comorbidities, which is the medical conditions that they have, the underlying hypertension, the diabetes, the heart failure, the dialysis, things like that. So unfortunately, if you have underlying medical problems and you're not taking care of those underlying medical problems, when you get sick, you just get sicker. You get much, much sicker. So the most important thing that we can do is, if we do have a diagnosis, such as hypertension or diabetes or heart failure, making sure that we adhere to the doctor's recommendations. So that means taking our medications as prescribed, monitoring our blood pressures, checking our finger sticks, making sure our sugar's controlled. You know, if you have heart failure, limiting your fluid intake, watching your salt, and, you know, nutrition, exercise. You know, I mean, these are all the things that we know and we've heard, but we really need to implement it into our daily life and make it a habit, a lifestyle. The reason why, you know, the wealthier people or the affluent people in the nice neighborhoods are not dying disproportionately than the Blacks and the Hispanics is, you know, when they have a diagnosis, they have a grip on the diagnosis. They have, you know, very good health literacy. They take care of themselves. They have great follow-ups. And, you know, they're able to kind of mitigate harm from that diagnosis. And our community have not been able to do that. And it's a social construct that's involved in that, but we're not going to get into that yet. But, you know, we really need to take care of our underlying medical problems. And if we can do that, then we will be healthier community as a whole. And we'll be less susceptible to these bad or adverse outcomes when it comes to, you know, things like infectious diseases and other diagnosis. And last but not least, what is an emergency? A reason to go to urgent care or the ER versus tele. So, I mean, I think an emergency is something that, well, you know when you're not well. You know when you're not well. So if you feel a little sick and you can get by and do things, you might be hesitant to go to the doctor's office, the ER. But if you're very sick, you know, this is not me. I can barely walk. I feel winded. I need to get to the hospital immediately. So I think we know what our baseline and what we can do at our baseline. And when you're far from your baseline, that's a sign that you need to be in a hospital being evaluated by a medical professional. If you are feeling a little unwell and you can still do a lot of the things, your functional status is still kind of the same, you can do a lot of things you were doing before, then maybe you can just use the telehealth, which is just, you know, telehealth is a big thing now where doctors are talking to patients kind of like how we're doing. Like I could be a doctor and you could be my patient and I'm asking you questions and you're telling me things and I'm trying to figure out what's going on. The limitation with telehealth is I can't do a physical exam, and a physical exam tells me a lot. So if you're a young woman and you have abdominal pain, you know, I don't think Dr. Andrews will be saying everything is all good because she might need to do a pelvic exam. And she might, not want to say it's okay, just take Tylenol and move on. She might say, I might need to see you here so I can make sure things are okay. So I think telehealth is good to a certain extent if you're not, for certain diagnosis and certain complaints, but it is, however, limited. If somebody's really sick and they feel unwell and they're not anywhere around their baseline and they can't do what they typically do on an average day, that's the type of person that needs to kind of take a visit to their urgent care or the hospital ED and be seen by a medical professional immediately. And I think I've kind of ran through all of those bullet points, and I think we can move on.
Thank you. Like the guy in the picture, right?
That guy's not going home.
That was awesome. A nice part that you picked on was health literacy. We're gonna move into questions. They're coming up, these questions in the chat. We was gonna try to stick with the 90 minutes, but we are going to answer all of the questions that you do have. But health literacy, again, yes, there are, folks that have a better outcome. They might have better insurance. They might have, different things. But part of the Black and Brown community, we are all part of the Black and Brown community. So we can speak plainly and openly. Our people need to take control of themselves. Our people need to take control of what they're eating. And there's been a big shift lately. Like, health is on the rise. A lot of people are reading about different things to do, how to control their sugars, their salts, their vitamins, and what foods. And I see the shift, and I think it's awesome, right? Calorie counting and stuff like that. And it's really, really good. And people need to understand that if they put that into practice more often, then when you do get exposed to some type of infectious disease, you can fight it. So I think that was really good that you touched on it, because it's really like a number one. So we have some slides coming up with questions that people emailed in or text me in or what have you, but I have some here in the chat. So let's move to these chat. Okay. I'm sorry. This is a lot of conversation. It's kind of cool. Okay, give us a long out explanation if you can. And that was about the shoes. So if you can, Shari, they would like to hear about this explanation about the shoes. And then we have, this is Rel speaking. Can you give us a pessimistic and optimistic projection on when we could have a vaccine with viable efficacy? Here we go. The vaccination question came up, but hold on, because that's coming up in the next few slides. And someone named Owner said, thank you for your wonderful work. And you are absolutely welcome. That is the reason why we're doing this. We just want you all to be better. Know something and spread it along. So let's go into that question, because that question was about vaccinations. And that's what this next slide is about. It's about the coronavirus testing, because there are different tests. So when you go to get a coronavirus test, that's what this picture is. Like, you have to get swabbed really far back in the nostrils, okay? And they have a blood test as well that's coming, but this is the go-to. Then they also have the antibody testing, which is to see if you have antibodies. And then, of course, the vaccination question. So whoever wants to take the questions first is, whoever tackles it. What does having antibodies mean? And what do the levels mean to have antibodies to corona? And if you do have antibodies, does that mean I'm immune? And can I get reinfected? And if you need me to answer and just read that question one more time. Okay, Owner, your name is John. Hey, John. It is, again, that question. Can you give us pessimistic and optimistic projection on when we would have a vaccine with viable efficacy?
Well, I can talk first about the different testing that is currently available. One of two tests, right? So if you want to know if you are infected with or have the coronavirus, it's the nasal swab, and that's the coronavirus test. It's not available yet, as far as I'm aware. by blood test at all. It is through doing this swab that does go far back in the nostrils, and that's what that's for. Now, let's say a person had the coronavirus or was exposed to the coronavirus. That means your body met the coronavirus and decided to mount an immune response, meaning there were some cells in your body that rose to the occasion and decided that we need to fight this off. We need to get your body better. Those cells are called antibodies. So the antibody test is performed through blood, and to find out whether or not your body has mounted a response against the virus. You can develop antibodies during an infection with the coronavirus, and you can hold on to those antibodies even after you've gotten over the coronavirus. The question remains, though, that if you are immune or develop antibodies towards the coronavirus, for how long are those antibodies effective? To what degree are we protected? Is it possible for us to get infected again? And unfortunately, we don't have answers to those questions. The development of a vaccination is essentially, the idea behind a vaccination is to be preventative. It is to prevent you from getting infected with the virus again. And it's not 100%, because much like a bulletproof vest, you can still get shot, right? So it protects you, but it might not be 100%. That's what they're working towards doing in case coronavirus is something that we need to worry about coming in seasonally, A, or B, for those who have not yet experienced or faced the coronavirus, to see if there's any protective measures that we can take so that they do not have to endure that. To develop a vaccination can take a very long time. It undergoes series of tests. And I think, as we've learned, the soonest that they think they can come together with a vaccination perhaps would be somewhere around 18 months, right? I don't know where we are with that. And I know that there's a lot of skepticism that's going around. I cannot lie that, you know, your medical professionals are probably on that bandwagon as well. When you come up with the vaccination, how can we know to trust it? Who gets it first? How will they decide? There's lots of questions. I don't have answers. We are all learning together. And I keep taking it back to that because Dr. Latif and I, we are not experts in the field, but we are medically trained. We use the knowledge that we do have to move forward. And unfortunately, we share those same questions with you. If you ask me from my experience, if I've seen patients where I question if they are reinfected, the answer is yes. I'll give you a case in point. Patient comes in, she had the coronavirus back in early March. She said that she felt like she was hit by a train. Let's just put it frankly. She had fever, body aches, she was in bed a lot. She said she had mild cough, but it was just really just feeling withdrawn and a lot of body aches. She got better. It took her a full, she said, 2 weeks to feel better. And she took even 2 weeks more before she returned back to work. But she felt better. She said, I'm back to normal. And she returned to work. She works at a hospital as a receptionist. Well, it's April 28th, and she's back in the emergency department, this time complaining of belly pain. And I said to her, I said, you know, I just want to do another test. I hope you don't mind. I just want to know whether or not if I test you, if it's going to be positive. I did a CAT scan of her belly. It showed me coronavirus. Her test came back positive. So then the question came up, was she always infected with the coronavirus? Or did she recover and then get it again? So we don't know the answer to that because it's not routine to test negative before returning to work, or if you had a positive, it's not routine to test again until you're negative. So it brings to a lot of light many, many questions. And we do not know if you can be reinfected. I don't know if Dr. Latif has any scenarios to bring up where he questions that as well. But classically speaking, if you have antibodies or you've developed antibodies against a virus or an infection, then you shouldn't get reinfected. But the question then comes up, are there many strains? Is it still possible to get infected with another strain or in another way? You know, those are all great questions. I don't know if Dr. Latif, if you want to weigh in on that. It's a great question.
No, I think you've kind of answered it to probably the same kind of knowledge that I have. You know, I think if you have antibodies to COVID-19, we say, well, maybe well, not maybe, you were infected at one point or you had exposure, whether you were symptomatic or not, and you developed immunity to it. But the information we have about this novel coronavirus is limited. So we're just not sure if having antibodies means you're, you know, really truly immune and you cannot be reinfected. So I think the thing is, you know, sometimes we send these people home, and like Dr. Andrews said, we're not testing them to make sure that they're negative now, because we don't know when they're going to be negative. But they're clinically better, so they can go home. And you know, they come back. So we say, well, is it, you know, they come back with symptoms, and now we retest them and they're positive. So we say, well, is this a reinfection or this is the same infection? So we're not sure. And you know, people who are antibody positive can feel like they have immunity, but I would still recommend kind of still taking the same precautions as if you didn't have it and not been infected before. So information is limited. Like I said, it's dynamic. Things are changing on a regular basis. So when we have more information, then we'll be able to put that. We'll be able to put this antibody positive versus negative into a true interpretation of what it means. So, you know, we're not sure right now. And we're just going to see. We have to wait for more information to come out. But I've definitely seen patients who were positive in the past, and then they got better, they went home, and then they were readmitted, and it's COVID positive again, and then the symptoms are now much worse. So, you know, we're not sure if this is the same thing or if this is a reinfection.
Thank you, guys. Thank you, guys. We're gonna move along. We're definitely moving along. Let me see. Okay, there's no more chat questions. I do have a question here that was text. I'm gonna move to the other slide because these were emailed over or text over as well. So I took some questions from the audience already live. I'm gonna move into people who sent questions. But I'm going to read additional questions that aren't here. So first question, doctors. Will wearing masks become the new norm forever? I think we addressed that already. If there's anything you want to hop in and say, don't mind, cut me off. We spoke about the vaccine. We kind of went into the second wave, and I think that's in this question too. Is it true that a lot of patients were dying because they were given too much oxygen on the ventilators? And I think that goes into a little bit of some things that have been circulating around about the ventilator settings, because at first, you know, it's new, and people were being treated accordingly, and you know, information was found out as it went along. I mean, I think the general public should have a place in their heart to understand that this is totally new to everybody, and you know, things have been learned. But can anybody address that question there about patients dying because they were given too much oxygen on a ventilator?
I would say, well, that's, you know, that's the one thing we really need to do is stop the sharing and the dissemination of false information. And that happens a lot on the internet. We live in a world where social media kind of, social media influences everyone, and there's so much information on there, and there's no fact check, and it's conspiracy theories and things of that nature. Could somebody have died from barrel trauma from too much oxygen? I mean, that's possible, but to say that the patients were deliberately killed because the doctors gave the patient too much oxygen, that goes against everything we stand for. So, that accusation is flagrantly false, and I'm repulsed by hearing things like that, to be honest. And I've seen two videos of nurses, accusing doctors of mismanaging patients. And what those two nurses failed to report is how doctors were overwhelmed and stretched so thin that, we were not prepared, and we did the best that we could have done. We took a Hippocratic oath, not just doctors, physician assistants, nurse practitioners, everyone who was involved in caring for these people, the nurses, the techs, all the frontline, the cleanup crew. We made a vow to come and help people at the hospital. So to accuse us of doing the wrong thing purposefully is just wrong. And again, as you take care of people, some patients do better with certain management. And with COVID-19, what happens is these patients develop what we call ARDS, which is a really bad lung disease, and requires mechanical ventilation. So ARDS management requires ventilation, and you have to manage the vents a certain way, which is the job of a critical care doctor. And they do what they can to try to help the patient's lung get better, but sometimes the patients don't do better. That's why I said before, if it comes to the point where you need to intubate someone, that person is sick.
Right.
That's the most important thing.
You explained before that if a patient needs oxygen, you'll give them oxygen. And then you went and you explained that if they need a BiPAP, they'll get BiPAP. Like, there's a progression of things before we get to the level of placing somebody on a ventilator. And if we're getting to the point where someone needs to go on the ventilator, as you've said before, is that the prognosis is already quite poor. And that means that we've also probably exhausted the need for other measures prior to getting there. So if we're getting to the point where intubation is required, which is the process of placing a patient on a ventilator, then we're already in a bad position. I think what we have learned along the way with COVID and respiratory issues is that just because a patient has an oxygen level in the 70s doesn't mean that they need to go on a ventilator. Sometimes you can simply give them oxygen by a mask and their levels will improve. It's to the point where they're working very, very hard to breathe, tiring out, not breathing well on their own. And, we're getting to a point where it's like, okay, you're not doing this well on your own, so now we need a machine to help you. We're getting to a point where it's pretty advanced. But to say that anyone is deliberately harming a patient, we took an oath to do no harm. And I know people can think of scenarios in the news and in media where you can argue that, but we're not doing any harm.
And I think we should leave that at that. We can move on to the next question.
Mm-hmm.
Yeah, we're gonna move along to the next question. But I appreciate that because there's so much to know, and it's very important to know that there's good and bad in the world.
Right.
Good and bad in the world. At the end of the day, to our doctors, I am the nurse. So when you guys put in your orders, I follow through with them. And as a nurse, you work with multiple doctors, and you can see people's hearts. And this is why I have you both here, because you have a heart. And mostly everyone does, okay? And that's a point to bring, is that everyone wants to help you. There is no way you're gonna come to a hospital and someone is gonna walk away from you. If someone walks away from you, that is something in that person. That is not to speak on behalf of everyone. If you come to the hospital, someone's gonna try to help you, and you're not gonna just walk in the hospital and then you get intubated. You're not gonna just go from point 1 to point 10 that quickly. There are steps. No one wants you to come to the hospital, be admitted, go through this whole suffering process. That's not the aim, okay? We're gonna move along. Next question. Other than income or neighborhoods, do you know of any, I'm sorry, I'm trying to read these fast. Other than income or neighborhoods, do you know of or have seen any noticeable difference in the treatment of people of color as opposed to other ethnicities? If none, why are people of color dying at a higher rate? I believe this can be answered quickly because we have addressed it in so many different areas. However, feel free to dive into it a little bit more, but we kind of addressed it. But go right ahead, doctors, and dive into this a little bit about the differences that we're hearing.
Okay. So just a couple of things. I'm going to make it quick. Why are Blacks and Latinos dying at a disproportionate rate? A few things. We mentioned it. The comorbidities, the underlying medical issues that they have already are not well controlled. So when you get sick with an infection, it hits you harder, and you get, you're sicker than somebody who has, well-controlled underlying medical problems. So that's already a big part of it. And that's a social construct, socioeconomic thing that has to do with, where they live, access to good health care, payment for visits, payments for medications. That's a social thing. That's a social, that's based on your social class, and that's a big part of the discrepancy in how healthcare is delivered in the country. The other thing is, these hospitals are working with less, and hospitals that serve these communities, these low socioeconomic communities, just have a lot less resources. And if you have less resources, then you can't do as much. And if you can't do as much, then the outcomes will be worse. So the two big thing is the hospitals are working with a lot less resources. They have to make the most out of really little to nothing and minimal resources. And then two, underlying medical problems that are not well controlled due to a lot of other factors, but most of it being your socioeconomic class and access to your doctors, medications, health literacy, and the likes.
All righty. So next question. Thank you so much, Dr. Salam.
No problem.
People are still out here barbecuing and congregating and not taking this serious. Can you tell us the real effects of coronavirus on your body? Do your toes turn black? What really happens that they don't show us on the news?
I think we've also addressed this as well through our talk. You're right, people are still out there barbecuing and congregating, perhaps not taking it serious. Do your toes turn black? There is such a thing that we've seen called the COVID toes, but it's very rare and sometimes can happen as like before you actually get the coronavirus. It's where the toes have this appearance of a deep purple or reddish, like a bruised appearance. What are they not showing us on the news? I'm not really quite sure. I just feel like on the news, we're hearing a lot of information about the lack of testing and the deaths that are occurring, and that we should wear face coverings and questioning the usage of gloves or even recommending it, but no one's really educating us on how to do those things. So I feel like, I don't know, Dr. Salam, if you have any input on that. I'm not really sure what they're not showing us on the news.
No, I'm not.
The numbers are real.
I'm not sure. I think I'm with you on that one. Like, I'm not sure what they're not showing us. I think the news is pretty much just kind of trying to educate us to what the numbers are. And I'm not sure what they're not showing us is, because, I think the news paints a grim picture of what's going on, and that's kind of what's going on in the hospitals that we saw, that we've seen.
Right.
All right.
I see it's the next question, so I'm just going to touch on it. Are the number of deaths because of COVID real? Because I don't believe it. People are dying for other things too. Well, I think if anything, the numbers are probably underreported. And that could be because there are deaths that are happening in the home or out of hospital that don't get recorded. There are also scenarios where a patient will come in already in distress and cardiac arrest, perhaps will expire shortly after entering the hospital. And if the physician or provider doesn't necessarily test them, we won't know if that's a COVID-related death or not. The numbers are real. And if anything, it's higher than we think it is. And think about the patients who have COVID, have sought medical care and didn't get a test, so they don't know, or the cases where their test came back negative and it was a false negative, but they really do have it. So I think that for sure the numbers are real and we feel it. We know it is. I could tell you one of our hospitals had 1,700 admissions for COVID and 550 expired or died. That's a lot. That's a third of the patients that came in. So I can only imagine across many hospital systems, like what their numbers, are. So it's real.
Yes, the numbers are very real. I agree. We had a lot of expirations. There was a lot to deal with, and it was hard on us physically and mentally. And I agree with Dr. Andrews that the numbers on TV probably is undercounting or underreporting the true numbers of death from COVID-19.
Yeah. Yes. So let's move on to flu season. What do you think will happen during flu season if COVID is going to come back when it gets cold?
We're going to be in trouble.
To say the least. Oh boy.
Well, flu season happens every year. Fortunately, there's a vaccine that everyone can take yearly once the flu season approaches. So we have to be vigilant in encouraging people to take the flu vaccine. I know people don't like to take the flu vaccine. So I think one of the things we must do this year is really encourage people to take the flu vaccine, especially if you have, COPD, diabetes, you're above the age of 60, 65, you really have to take the flu vaccine because it's gonna, give you a chance of maybe not having the flu. And then if you do have the flu, because it's not 100%, we know that, maybe your symptoms are not gonna be as severe. And with COVID, we don't know what's going on. It could still be around. So, there's been cases, although not many, where someone had COVID-19 and influenza. So you can be co-infected. They're not mutually exclusive. So you could be co-infected, and if one is bad, two will be really bad. So take the flu vaccine. Let's hope that a vaccine for COVID-19 will be out soon. It's not going to be so soon. I don't think it's going to be this year, but everybody's working. The pharmaceutical companies and the governments are working really hard to try to find a vaccine. But I think what's important right now is at least we know we have a flu vaccine. So please take the vaccine yearly, especially if you have medical problems already and you're above the age of 65.
Thank you. Next question. This one is talking about mental health. There have been at least 4 suicides at Elmhurst Hospital in Queens. My friend has a daughter who's a nurse who has been contemplating death based on the conversations they had and her wishes for her children. As doctors, are there any mental health courses offered to you and for any healthcare providers on the front line?
Yeah, actually, one of the top physicians in our health system personally called me, but not just me, but other providers as well, to say, hey, how are you doing? How are you holding up? How are things at home? And I think that was done because they are realizing how heavy all of these cases weigh on our mental. A lot of us in one way or another have taken sacrifices in our household even. For example, my 10-year-old son, I've been quarantining myself from him since the start of this. Yeah, okay, restrictions have loosened up. I'll see him more, but I'm wearing my mask. I'm being so vigilant about making sure my hands are clean. You know, like, it's difficult because, yes, it does weigh heavily on mental health. And are there any courses that are offered? I don't have any courses offered to me, but it is known that we have like a code lavender. If you need to talk to somebody, there are people available. We have received pamphlets to say that you can have a free and confidential sit down with someone if you need to talk professionally about anything, off the record as well, which is nice to hear and understand and know, if in case you want to take advantage of it. So I do think that there is a positive outpouring of support that I've seen. Mm-hmm.
I also think for people to understand that New York is not inclusive. There are many health systems. You have the city health system. You have Mount Sinai health system. You have Northwell health system. You have, what are the big ones? Presbyterian health system. You have Downstate. You have, I heard there's a new health system trying to rise up to battle Northwell. So you have all of these different, you have Maimonides, which is, they're standalone. They're not with any system. And every system do things different. Every system have their different protocols. Some systems will extend their hand and give a month off. And some systems are not giving tests at all and come back as soon as you can. Some systems are like, what is it, Montefiore up in the Bronx. They were fighting to not use their personal time off because of their COVID infection. So I think it's also important for people to understand that one thing doesn't apply across the board. Dr. Salam, is there anything available where you're at that might be different?
He's on mute.
I didn't mute him. Let's see. Let's unmute you. Are you unmuted?
Okay. Can you hear me?
Again.
Okay. No, I was saying at my hospital, our psychiatry department was involved in speaking to all of the doctors. We had therapy sessions, group sessions where we just kind of, spend an hour and just kind of, speak and vent and come up with ways to kind of deal with the emotional trauma from dealing with, what COVID-19 has caused. So that was an outlet. There was, they gave us other coping mechanisms like, yoga and Tai Chi and, things that could help you relax and help you deal with, what's going on, because, there was a big weight on a lot of us seeing people die the way they did. And, I think the psych department did an excellent job where I work to try to come to us and give us help if we were asking for it. But, not even if we're asking for it, they came to tell us, listen, we want to give you guys help anyway. Let's just do this group sessions. So we would have like a group session once a week. And that was very good. That was a great way of just kind of venting and speaking up and just kind of sharing experiences. And we all had a lot of, similar feelings about what was going on. So, that was a great way that we kind of dealt with it where I worked.
That's excellent. People, it's a lot because your first instinct is to help, So when you're seeing that you're putting all that you can into helping a person and it doesn't go the way you planned, and then before you can close your eyes is a line long of more coming, more coming, more coming. You go home to wake up, you know the next time you work is the same thing and it's still coming. And you go outside and you see people just not taking it seriously. It both affects you emotionally from at work, and then it just frustrates you emotionally when you're out of work. So I think that's a big deal. So this last question on this slide, because I see a few chats, and we're going to cap those chats so that we can wrap it up. Last question is peace. So I know this is Shari's area. Dr. Salam, if you have anything also, you know.
No, I'll defer to Shari.
There's been a lot of talk about the effects on the elderly and that the younger people can be asymptomatic carriers. But now children are dying from COVID or COVID-related conditions with atypical symptoms. What do we need to know about COVID and children to protect them? Yeah, so as of lately, there's this pediatric multisystem inflammatory syndrome, and they are questioning if it's related to COVID, as obviously we are enduring a pandemic, and here we are with this new syndrome. Well, it's not new exactly. There's an existing inflammatory syndrome that is very similar to it called Kawasaki's. And Kawasaki's usually you will see in children less than 5 years old. They would usually have a fever for at least 5 days. And on top of that, a myriad of other complaints, like you'll notice that their eyes are red like pink eye. You'll notice that there's a rash. They could also have like swelling of the hands or redness of the hands and feet. Their glands can be swollen, especially in the neck. And all of those things are actually, if you think about it, quite common in viral illnesses. But the problem with this kind of an inflammatory syndrome is the deleterious effects that it can have on the heart. It can cause the arteries of the heart that feed the heart to sort of swell or weaken or develop what we call like an aneurysm of sorts. Now, whether or not it's related to COVID is still the question. I mentioned children less than 5 years old. That's for Kawasaki's, but for this, it's not just children under 5. I believe the first reports of it was around May 6th or 7th or so. And on day 1 of reporting this through the media, we learned that there were at least 80 cases and 1 death, I believe, in a 5-year-old. But by day 2, there were 200 cases and 2 deaths. And then day 3, you know, so as you can see, it was becoming exponentially an issue. So bottom line is for our children, what they notice is that they're not necessarily currently infected with COVID, but if you test their antibodies, that they would have antibodies, which means that at some point they were exposed to the virus. So then you wonder, well, okay, is this an after COVID type of a syndrome that they're having? Is it incidental that they happen to have also antibodies to COVID and then this is happening too? Well, they've had some reports in Europe, and those reports in Europe are what sort of brought the awareness to us here in the States. And ultimately, the bottom line is to bring awareness to you guys for our children, that if you notice that our kids are having fever that's lasting at least, I would say to you, 3 days. And in addition, there are red cracked lips, a tongue that looks like a strawberry, very red with white dots. If they're very irritable, sluggish, you notice rash, diarrhea, and you have a concern, then to be vigilant, get in touch with the pediatrician. If there is an issue that you are emergently concerned about, then I would go to the hospital. But you should be aware of this because this is new. This is new in media, and we just want to make sure our community is aware. Because when you start talking about our kids, we don't play.
Absolutely. Like you have your 10-year-old, I have my 6-year-old, and I mean, I know what you're doing, and I just, man, when you start talking about people's children, you looking for war.
Yeah. Yep.
And he's here now asking me for V-Bucks. I'm sorry, guys.
V-Bucks. Oh, I know all about it.
So now that we wrapped up those questions, let's answer. We have 4 chats. Let's see. What should we expect this fall? Is there anything we can prepare for? We addressed that. Oh, tell the doctors and yourself you are loved and appreciated. God bless you and your service.
Thank you.
Thank you very much.
So any hands up? Anybody want to raise a hand, say anything as we wrap this up? This was pretty awesome. Let me move along. Did everybody enjoy this? You can put your thumbs up.
How do you do that? Oh, I found it.
You gonna put your thumbs up? Well, I thank you all for participating. I really hope that whoever is on here did pick up a lot of information. This was very, very informative. And it is on record. You can share it. And let's just get ready to take care of ourselves and one another. And if it isn't, it was Spanish flu, it was H1N1, it was bird flu, it was Zika, it was Ebola. Like there's always gonna be something. It's time people learn, right? Like take control of the things you can take control of, which is your health. Let's see.
Indeed.
You know, I want to say thank you to you, Melissa. I mean, for putting this together. I think that I wish everyone can hear it, but you know, it's successful if one person walks away from this with more knowledge than they walked in with. And I think that a lot of great information was shared. I want to thank you for putting this together because it does bring awareness, and awareness is always a good thing. I feel like going forward with New York reopening, which is going to happen slowly but surely, on its own or not, we should just make sure that those basic fundamental principles are widespread and understood, that we should be strict about isolating, right? Physical isolation, as you've put it, Dr. Salam, correct? Great hand hygiene, and I say great hand hygiene, like get crazy about it. And being vigilant about symptoms when severe. Don't be afraid of going into the hospital. We are here to help, right? And at the end of the day, it's a matter of making sure that you get the medical attention you need when you need it. So I thank you.
You're so welcome. You're so welcome. I thank you guys. And just to tag on with that, coming to the hospital where I'm at working now, because the non-COVIDs are coming back in, they have put one elevator for the non-COVID patients, and they have a whole floor for the non-COVID patients. So therefore, they're trying to eliminate as much as possible, as humanly possible, those who are infected and those who have yet to be infected or are not currently infected. And they go up an elevator, it's just for them and the staff also. So now that we have the spacesuits on, if we're taking care of these patients, we have to take those spacesuits off. There are no spacesuits allowed on the floor. And then when you go back to the ER, wherever, then you, hopefully there's not a shortage. It gets some more.
Yeah, I'll just add, thanks for putting this together, Melissa. You know, it's a good way to educate the people, enlighten the people who are tuning in, and, you know, even enlighten ourselves. I learned stuff from Dr. Andrews, and I hope she might learn something from me also. And I learned something from yourself, you know, as you spoke. So, you know, it takes, it looked like it took a lot of time and it takes a lot of dedication to do something like this. So kudos to you for a job well done and for bringing us all together. And, you know, I think this is important for the Black community, right? Like we have to be the voice to advocate for ourselves, because if we don't do it, nobody's going to do it. So, you know, we have healthcare professionals here who are willing to talk to the people and educate them and let them know what they should be doing, what they should not be doing. And I think it's a great thing that you're motivated enough to put this together and create the platform to send the information out there. So again, thank you very much. I hope people got a lot of information from this, and they can practice it. We're not out the woods, the woodwork yet. Just kind of try to do what you can. It's hard. We know how hard it is. My wife and I, we struggle with staying inside the house all the time. We're so bored, but we're not doing it for ourselves. We're doing it for other people. So don't be selfish. And let's deal with that. That boredom and all that. Not so much fun now, because there's gonna be time. It's gonna pass, and we're gonna get back to living life the way we know. It's just a matter of being patient. And yes, it's hard right now, but follow the rules. Try to do your best in doing what we're asking you to do. And already it's gotten better. It's not gone, but it's better. And hopefully will continue to get better. And when we open up, we'll continue to see numbers go down, hopefully. And if we do get a surge, nothing that we can't handle like what it was 2 months ago, a month and a half ago. And better days are coming. Just be patient.
Thank you, guys. Thank you for these kind words. We have a lot of thank yous coming in on the chat. And Deborah says, I'm so proud of each of you medical professionals and sincerely thank Tiffany Salam for inviting me. Thanks for your service.